So I would like to say welcome to all the attendees for this second webinar on family-centered care, an initiative that we took within the 99 NICU community some time ago. And the reason was that we believe that family-centered care and kangaroo skin care, etc., are very important strategies to improve outcomes in infants and parents. And today we have three distinguished speakers in the panel, Professor Stefan Swartling Peterson from Stockholm, Dr. Suman Rao from Bangalore and WHO Geneva, and Dr. Agnes Linnér from Stockholm. And for the attendees, I would like you to put your questions in the Q&A, and you can also raise your hand and we unmute you, so you will be able to speak directly to the panelists. Structure is Stefan Peterson is have to go away for another commitment after his short introduction, but we will have a few minutes to ask questions to him, and then Dr. Rao and Dr. Linnér will have their presentation, and then we have a moderated discussion after their presentations. So welcome everyone, and welcome to the panelists. Thanks so much for joining us. And now, Stefan, I give you the word.
And thank you, Stefan. What a delight. From another Stefan. Stefan Swartling Peterson, professor with Karolinska Institutet. But I think I was approached to talk here from my previous job with UNICEF. I was the chief of health for UNICEF globally the last couple of years, and now that I'm back to Sweden, I carry the UNICEF brand, still advise UNICEF Sweden. Now, I wanted to say that this year, approximately 140 million children will, and some 2.7 million of those will die within their first month of life. Another 2.6 million will have died in the last trimester and be considered stillbirths. Those were the dates prior to the pandemic. And we are afraid that with the raging pandemic, lockdowns and more home deliveries, etc., those numbers and the perinatal deaths of both mothers and babies we may go up once we get those statistics. Now, the whole idea around newborn mortality has, of course, long been a focus in many countries, Sweden, but in terms of global health, it is a relative newcomer that international organizations and the global health community focuses on. It was actually in 2014 that 194 countries in the World Health Assembly endorsed the Every Newborn Action Plan, ENAP, Action Plan, with various follow-up and report backs to the World Health Assembly, etc. And in many ways that spurred a lot of action in this otherwise previously, I would say, neglected field. The way forward to tackle all of these deaths is, of course, improved coverage and quality of care around childbirth for mother and baby, for everyone, and around the world. But particularly, given your interest here, the small and sick newborn are, of course, the ones who are even more vulnerable to die. UNICEF estimates that some 30 million newborns per year require some kind of inpatient care, 30 million out of 40 million. And obviously, to scale this up, coverage and quality, small and sick newborn, it requires a health systems approach, much not more than some individual technological intervention or training of health workers, etc. I think we've seen impressive examples of how Bangladesh and even Sierra Leone have started to take on health systems approaches to newborn survival. Now, I thought, obviously you'll hear from the experts here some of the new advances in how we But what I wanted to leave you with was a brand new report launched, or rather an implementation toolkit 3 weeks ago by ICF and Nest 360. It's called the Newborn Toolkit. The new Stefan can put in the chat, because it has everything that you need, from including floor plans of how to remodel your hospital so you can fit in an intensive care unit, and where should the bathroom in relation to the patient room, all the way over infection control to how to train and inform around. I must say it's an extremely impressive product that has newborntoolkit.org, and I can only recommend formally you take a health systems approach to quality of care and small and sick newborn. Stefan.
Thank you, Francesco, for unmuting me. And thank you, Stefan, for this introduction. So I would like to ask the attendees to begin with, do you have any questions? Please place them in the Q&A or raise your hand and we make you unmuted. And until they are thinking, I would like to ask you, Stefan, can you explain a little bit about how this toolkit came about? How was the working process and who was involved in this?
ICF has an interest in newborn. Hired away Gagan Gupta from India, and he has worked very successfully with Nest 360, which is a number of organizations that technology field actually take a systems approach. So together, this was some work I initiating a couple of years ago. Players, including Joy Law, I'm sure you're familiar.
Joy Law, yes.
Work very hard and making it a practical. Actually, mission is to cover every aspect as you plan from the first idea and remodel hospitals and infection control, etc., with a focus on low end. So we're quite hopeful and happy that the product, and hope that it to practitioners
another question that sort of has come to me, I mean, as we all know, nowadays prematurity and not infections are the leading cause of death. In the 5-year mortality rate in children, the leading cause is now preterm delivery and not infections. Do you think that this is like a new context or paradigm that is less easy to grasp? Because most people think about preterm babies as something that people in the rich world cares about. What are your thoughts?
From my qualitative research, when I work with colleagues at Makerere University, it's clear that every child is a loss, and stillbirths, quote from both and from health, is called weeping in silence, because culture may not necessarily say that this stillbirth was a child, it's premature, but nevertheless, on both health workers and mothers, it is a burden. So I think in all contexts, this is an issue. We also need to think the technical aspects of it, but also the socio-cultural aspects around it to get this awareness. But the loss and the grief is there. So I think it's definitely something we can do something about. Now, from a technological point, compared to previous challenges and so on, obviously you require more technology, stuff, something else. It's of course a challenge from a health systems perspective.
Yes, yeah, that's right. Yeah, and I think this sort of reasoning around small and preterm infants and newborns. That's, I think, also a bit similar also in the developed world, because we also struggle with a notion that, or this is my personal now reflection, Francesco, Agnes, Suman, Vicky, please fill in, but sometimes the public opinion about neonatal care differs from pediatric care and what it's worth and so on. So I think
I challenge you, as I challenge the colleagues around the world. So as we start to save an increasing proportion of matures, we will also need to think follow-up.
yes,
From a disability perspective, seeing neurocognitive, physical, all aspects of disability, that we need to plan this already, discharge these. Again, the work I've been part of on disability show that it's a very sad situation in many places around the world. Through Karin Andrews' work and us in Uganda, we've seen that the dominant burden in cerebral palsy in Uganda is post-infectious in children post-birth, and while the dominant cerebral palsy burden in Sweden context comes from the prematurity. So I think as you start saving babies around the world, adding new forms of disability, discharge should not.
Okay, thank you so much. Is there any other question from the attendees, or Vicky, Francesco, Agnes, Suman? Then I would like to thank you, Stefan, and wish you a nice evening with your new commitment for the evening, or the next commitment for the evening.
Seminar, and again, congrats. If there's one technology which is ready for scale up, it's Kangaroo. Now that you've extended Kangaroo Care to a target group, go Kangaroo, go.
we jump away as kangaroos.
Thank you.
Thank you, Stefan. So now that Stefan has had to go to his next commitment, I would like to give the word to Dr. Suman Rao, neonatologist from Bangalore, India, and strongly connected to the WHO in Geneva as well. Please, Dr. Rao.
Thank you very much. And yeah, I can share screen, so probably I'll just jump into my presentation. So Stefan has told us to go Kangaroo, and that is what we are going to do now to sort of discuss. I think you can see my screen, and there you are. So please confirm that you can see my screen in full scale.
Yes.
And you can hear me well. And so we are going to go Kangaroo and act now. And I'm going to share my experience on these things. And as we just heard, I think the focus is on the preemies as well as the low birth weight. And every year we have around 20 million infants who are low birth weight, 15% of all births. But though they contribute to only 15%, they account for a huge 70 to 80% of all neonatal deaths. And of them, 95% are in LMICs. Not only do they contribute to mortality, but just like what you heard now, it's very important to follow them up because they're at increased risk of early growth retardation and developmental delay. And we do have one tool, and that is Kangaroo Mother Care, which is something that if we can scale up, we can make a big difference. And we all know the components of Kangaroo Mother Care. First and foremost is the continuous and prolonged skin-to-skin contact, as long as possible, preferably more than 20 hours, with exclusive breastfeeding, and also early discharge with a focus on adequate follow-up. And when Kangaroo Mother Care is implemented, it has a huge reduction in mortality up to the tune of 40%. Not only that, other morbidities which are so many in low birth weights, like sepsis, hypothermia, hypoglycemia, Kangaroo Mother Care is one single intervention which can make a huge reduction in these morbidities. not only in the newborn period, but even subsequently into infancy, there is reduction in hospital readmission rate, there is improved exclusive breastfeeding, improved growth. We all know this. This is not new. And we know that the current WHO recommendations recommends Kangaroo Mother Care to be started in health facilities for babies who are less than 2,000 grams. And it recommends that you start brief sessions of KMC, and I'll use the word KMC as short for Kangaroo Mother Care. It should be initiated when the baby is beginning to stabilize. And then once the baby is fully stable, give as continuous KMC as possible. This is the current recommendation by WHO. But if we look at this, a huge number of low birth weight babies are going to fall out of this net. One big section is between 2,000 grams and 2,500 grams. The second is babies who are born and who are not yet stable. We know that most deaths occur in the first day and most occur in the first week. And if Kangaroo Mother Care has to be started only for stable babies, these babies are going to fall out of the net. So by looking at these questions, WHO started a series of 3 large trials and studies to focus on these issues. And first and foremost, the issue was about the coverage of KMC. We know the huge benefits, and it's not really new at all, but still the coverage of KMC is very low globally. So WHO looked at studies to see how we can do implementation research to achieve high coverage at scale. The second large one was to look at whether we should restrict Kangaroo Mother Care to be initiated only in hospitals, or it looked at an efficacy study looking at community-initiated KMC. And lastly, which Agnes will be talking about later, is can Kangaroo Mother Care be started for unstable babies? So these 3 trials is what we are going to be discussing in the next 20 minutes. In short, scale-up KMC or SKMC, community-initiated KMC, and immediate KMC. And I'll talk about the first 2 here. And the scale-up KMC was a study implementation research initiated by WHO in Ethiopia in 4 sites, and in India in 3 districts. And I was a PI for one of the sites, and that is in Koppal in Karnataka. And what we got at the beginning of this study was, we got our goal that you need to have a population level coverage of up to 80%. You can design the model which will help you achieve that. But one thing that all the 7 sites which were involved in the scale-up KMC focused on was in the pre-facility to see how we can get these low birth weight babies to the facility which is implementing Kangaroo Mother Care, give them good quality Kangaroo Mother Care in the facility, discharge them, but follow them up into the community where Kangaroo Mother Care is continued. So this was the way this study happened in all the 7 sites, but they were contextual modifications to the model. And I'm going to bring you learnings from mainly from my side, but this was very similar to the others. The first and foremost was we need to weigh the baby accurately. Because when we undertook this low birth weight validation study, when we looked at babies and said, are we measuring their weight well? Because that was the entry point into Kangaroo Mother Care. We found that 25% of the babies who were labeled as normal weight were actually low birth weight. And if you had the exact figure of 2,500, 2/3 of the time they were actually low birth weight. In fact, number of babies identified by the research nurses as low birth weight was almost double that what was identified in the facility. So one thing the WHO did was to ensure that all the sites, every birthing unit in the 7 sites, were provided with digital weighing scales. The second most important thing is, yes, Kangaroo Mother Care is no cost, low cost, but you still need to have some basic infrastructure for Kangaroo Mother Care. When we are looking at continuous and prolonged skin-to-skin contact, you need a binder. You need the comfort of the mother. You need reclining chairs. And especially for stable babies, when you're giving continuous KMC, having a Kangaroo Mother Care ward in the facility was an absolute essential infrastructure that we needed to create. In the NICUs, in India, it is a mandate that we have an adjacent Kangaroo Mother Care ward. But we do know that the larger babies are all in the postnatal ward. So an area in the postnatal ward for Kangaroo Mother Care was also created. But one very, very important aspect for the success for implementing KMC is how we counsel the families. The families are not against Kangaroo Mother Care. In fact, we do not find the families, the mothers as barriers at all. But at the same time, to make them do prolonged KMC, to support them, I think we need to really focus on counseling, particularly peer support and hands-on support. And here we had human-centric designs to try to help them do prolonged KMC. And here you see a group of mothers who are actually playing snake and ladder. And here the snakes and ladders were looking at the benefits of Kangaroo Mother Care and the harms in low birth weight. So this was one way of that we looked at how we can educate and encourage the mothers. Probably one of the biggest barriers we did find was the health workers themselves, because they have a great fear of giving over the responsibility of these tiny babies to the families and mother. So conviction of the health workers, training, skill transfers, and keeping them motivated was a very important aspect of the trial that the study we conducted. Kangaroo Mother Care is not an intervention to be done in isolation. We need to ensure it is integrated in the continuum of care, right from the labor room into the community and till the baby is throughout the newborn period, and probably till the baby sort of refuses Kangaroo Mother Care and comes out. Community involvement is absolutely essential. And especially since we are discharging these babies early and we want Kangaroo Mother Care to be continued at home. And here you see during the trial, these are public transport buses in the Koppal district, the site, which had these things about Kangaroo Mother Care. And here you have what we call jatras or fairs highlighting about Kangaroo Mother Care, and any type of media support for this really had a positive influence. And we were trying to get the whole families, including fathers, to practice Kangaroo Mother Care. But what is important, that there is a constant feedback to the teams. And particularly we found that when the government is involved and when Kangaroo Mother Care is used as an indicator, it helps in scaling up. In fact, Kangaroo Mother Care is going to be coming out as a newborn indicator globally to ensure that this tool can be scaled up rapidly. This particular paper from the 7 sites has been recently published in BMJ Global Health. And what we did find as results was this: from less than 5%, in just 2 years' time, a focused implementation research and implementation model could take Kangaroo Mother Care at a population level coverage to more than 80% in all sites. And we also looked at good quality Kangaroo Mother Care. That is, we said that at least 8 hours of kangaroo skin-to-skin contact and exclusive breastfeeding. And with this implementation model, this could be scaled up to more than 60%. The mean age of initiation was around 3 to 4 days, and they continued Kangaroo Mother Care to more than 20 days even in the community. Here, I would just like to share a story of triplets, because Kangaroo Mother Care, it's not just a tool to reduce mortality. We do believe that it's a tool which can bring about equality, equity, and dignity. And this story, which I would like to narrate to you all, talks about this. This lady, she already had one girl child, and then she had triplets, all girls. And in some areas in India, unfortunately, we still have this gender thing that they want a boy baby. So when this lady delivered 3 girls in the hospital, her family was all keen to just take the babies away without continuing care. The support which was given by the team in the district hospital, and here you see all the 3 triplets in Kangaroo Care. And in fact, they took on the onus of taking care of this baby and supporting the mother and the mother was convinced to stay back till all her 3 girls were better and could go home. And with the support of the DH team, the district hospital team, the family was also convinced, and this team in fact took care of the entire hospital care and even beyond for these babies. And now you see them as 5-year-old girls now. And in fact, this story was taken up by WHO, and it even was published in the Lancet as a health story in focus. Now, this particular story, when it got media attention, gave us a lot of impetus for Kangaroo Mother Care scale up in the Koppal district. So just to state that, yes, having a good model for implementation, it is possible to scale up Kangaroo Mother Care very rapidly to more than 80% of any KMC and more than 50% of effective KMC. And we saw this across all sites. Next coming to, and this is going to be another 2-3 minutes, the other big study that WHO was involved with, which has been published a couple of years ago, was the Community-Initiated Kmc Study. Till this study was published, the recommendation was that it should be started only in the facility. This study had the primary objective of looking at, if we started Kangaroo Mother Care for low birth weight babies in the community, what is its impact on mortality and also on exclusive breastfeeding, growth and infections till around 6 months of age. And here, this was an individual re-randomized control trial with more than 8,400 participants. This was done in Haryana district of India. And here all babies who were less than 2.25 kgs by less than 3 days were enrolled into this study, either if they were born at home or even if they were born in the hospital, if they were discharged early less than 3 days and had not been initiated into KMC, they got enrolled in this trial. The figure 2.25 kgs was taken so that we could actually reach out to all low birth weight babies, and we know as they lose weight in the first 3 days, so therefore a figure of 2.25 kgs was considered. And the intervention was KMC initiated in the community by the community healthcare workers. This study managed to implement KMC very well. As you see here, the duration per day in hours was around 11 hours of Kangaroo Mother Care, and they continued KMC almost throughout the neonatal period. And here you see that Kangaroo Mother Care brought out a reduction in newborn mortality by around 30%. And this reduction in mortality continued even till 6 months of age. So this was another large trial, which is going to change WHO guidelines. And it shows that community-initiated Kangaroo Mother Care reduces mortality. And this is another way of scaling up and improving the coverage. And even in babies who are between 2 and 2.5 kg, it does have a big reduction in mortality. The third large study, which has taken the world by storm, I would say, is the immediate Kangaroo Mother Care study, which Agnes will continue to talk about. Thank you, and back to you.
Thank you so much, Dr. Rao. So before any questions, may I give the word to Dr. Agnes Linnér from Stockholm. Are you with us?
Yes. Can you hear me now?
Yes.
Yeah, so I'll try to share my screen. And there. Mm-hmm. Yes, and I think you can hear me and you can see my slides now, right? Yeah. So first of all, as Stefan said, I'm a neonatologist working mainly clinically in Stockholm, but I also have my PhD project about skin-to-skin contact in Sweden, and I was also a part of the Ikmc trial together with Dr. Suman Rao and many others. So I'll just go through the background and the rationale and the results from the Ikmc study. And Suman already mentioned that before this study, we thought a lot about the Cochrane results showing the 40% mortality reduction with Kangaroo Mother Care as we knew it, meaning initiated when a small baby is stable. But also, as Suman said, we know that small babies, they die early. So if mortality is reduced by Kangaroo Mother Care initiated after a couple of days when a baby is already stabilized, then looking at this picture, you understand that many babies don't ever get the opportunity of Kangaroo Mother Care. And that was the reason why we wanted to look at that. What are the effects of skin-to-skin contact or Kangaroo Mother Care early in parallel to the neonatal care? And the idea of this study actually came from Karolinska Institutet, or more exactly from Dr. Nils Bergman and Björn Westrup. But WHO took the lead and organized this multi-center study with lots of investigators from different countries in India and in Africa, so low and middle income countries, 5 sites. So the study design was basically, we looked at infants with the birth weight between 1 kilo and 1.8 kilos. And I'm explaining lots of background details here because I think it's interesting for understanding what the results of the study means also. So why these weight limits? Well, infants above 1.8 kilos, they're not always admitted to a NICU. Usually they can be quite stable and be assessed and then sent home directly. So we couldn't really recruit babies above 1.8. And below 1 kilo in these settings where we did the study, then they need other things that sometimes cannot be provided at the sites. So those were not included either in the IKMC trial. The intervention was Kangaroo Mother Care with a mother or with a surrogate caregiver initiated at birth and continued until stable. And the group predefined a number of stability criteria for this. The control group received conventional care, and conventional care at the sites was, it was different between the sites, but basically the infants were admitted to NICUs where the mother didn't stay but came and went for feeds. And short sessions of KMC was started when the infant started to stabilize, and then included in the conventional care is the later KMC. So as soon as the infant was stable, conventional care was continued as Kangaroo Mother Care in a KMC unit, because KMC units are available all over the world as sort of step-down units after NICU care before going home. So the outcome, the primary outcome, was shared or divided mortality outcome. So neonatal mortality, meaning mortality at 28 days, and also the early mortality at 72 hours was the primary outcome. And then there was a set of secondary outcomes. So one was time to meeting these stability criteria. Another was hypothermia, proportion of temperatures below 36 degrees. And we looked at hypoglycemia, invasive infections, a number of breastfeeding outcomes, length of hospital stay, maternal depression, and the overall maternal satisfaction with the care. And there was a number of exclusion criteria as well that you can see here. And the reason for mothers too sick to provide care within 3 days, the reason for that being an exclusion criteria is that it was quite demanding for the surrogates to stay with, for example, a sister child for long days. Then we couldn't rely on a surrogate to provide the KMC for many days. So we only used surrogates as a temporary solution before the mother was available. Yes. If you want to know more details about the actual protocol, then this was published also in Trials in 2020. So you can go back if you are interested about the details. And the paper itself was published in May this year in the England Journal of Medicine. And we had an antenatal screening strategy because we wanted to start the Kangaroo Mother Care as soon as possible after birth. So we approached pregnant women in the antenatal units, in the delivery units, to get the pre-consent, and then the children were assessed after birth, and if they were eligible, then they were randomized and allocated to either IKMC or to control. We planned in our protocol to include 4,200 infants, and that was with a power calculation estimating a mortality reduction of 20%. And as you can see, we ended up with 1,609 children in the IKMC group and 1,602 in the control group. And that's because after about 75% of recruitment, the DSMB did an analysis and found a benefit, a very clear benefit in the intervention group, and then they recommended early stopping of the study. That was in January 2020. This is how our mothers and infants looked like. So the average baby was born at a little more than 32 gestational weeks, birth weight 1.5 kilos. A little less than half were male, a quarter twins, and you can see that most of the babies came from Delhi in India, a very busy delivery unit, and then the others from Tanzania, Malawi, Ghana, and Nigeria. This is what the intervention looked like. So you can see that the KMC is performed in parallel to the neonatal care. So this was the new thing, that even if the baby needed CPAP or IV fluids, or the mother needed care, the KMC was done at the same time. So they were attached to the mothers or surrogates with these shirts, and they were given all the care in that place. We achieved a very high, or the mothers and children achieved a very high dose. So during the first days, a median duration of 16 hours per day. And that's a lot if you know what skin-to-skin hours are, at least in Scandinavia. So 16 hours is a lot. The children all had pulse oximeters, intervention and control babies, and they were monitored 6 hourly. So 4 hours daily. We collected vital parameters and support data from the children. And the results, I think you know them already, but we found a 25% mortality reduction at 28 days in the intervention group. The effect was not statistically significant at 72 hours. For the secondary outcomes, surprisingly, nothing statistically significant for the pre-specified breastfeeding outcomes, because that was something that we had thought as one of the mechanisms behind the beneficial effects, but nothing that we could find here anyway. Known since before is that babies maintain a good temperature in skin to skin, and we could see that too. So very nice reduction in hypothermias in the IKMC group, and also a nice reduction in sepsis cases with IKMC. And this is a stratified way of looking at the results. So here you can see the results as a forest plot looking at birth weight strata, gestational age strata, and also for the sites. And you can see that the effect is beneficial almost in every category or in every strata. And we will be looking at the mechanisms and some of the socioeconomic factors and physiology data later on. So there's a lot of planning for follow-up studies and mechanism studies going on at the moment. And speaking of Dr. Peterson Swartling's comment there about saving newborn lives, then you also need to follow up. There's a follow-up study also going on to see how these IKMC babies are developing later in life. Thank you.
Thank you, Agnes. So we have another 15 minutes to go until 6 o'clock Swedish time, at least. And I would like to open the floor for the attendees. If you have any, if you would like to speak up, just give us, raise your hand and we unmute you. May I start to share one question that I was thinking of? What is the potential? Assume that Kangaroo Mother Care would be available for all low birth weight infants in the world. What would the potential be in the reduction, the reduced number of infant deaths globally?
Yeah, maybe I will just take that. There's a huge potential because, in fact, we looked at this as if we add now community-initiated KMC, because there's a huge number of babies who are between 2 and 2.5 kg. That means probably another 350,000 more babies will be saved. Then in addition, we are looking at Ikmc, another 150,000 babies can be saved. Now with scale-up KMC, where we are talking about from 20% to, or less than 5% to 60 or 80%, that's another 250,000 babies. So the potential, if we can go to scale where every baby who needs KMC gets it, I think it is going to be a game changer.
So we're speaking about hundreds of thousands of infants could be have a saved life thanks to this kind of simple intervention. That's fantastic, I think. Francesco, you had something in the chat.
Yes, my question is like what, and it's for, especially to Suman Rao, what do you believe is the biggest barrier in implementing KMC in these countries? And is that different from country to country?
Across both the countries where scale-up KMC was taken up, the families and the mothers and the families, which many perceived could be barriers, were just not there. They were all ready to embrace Kangaroo Mother Care. Now, in particularly in India, what we faced was that the conviction of the health workers was absolutely essential. Now, particularly the nurses and the doctors, they are used to taking care of these babies. And the mother would come as a visitor, if at all, and see the baby and go away. Now we are talking about giving the whole responsibility of these small babies to the mother and the family. And that was what needed to change, where they needed to understand that it is perfectly not only all right to get the mothers, it is actually helpful and beneficial to have them in participating in the care. In fact, what we talk about family participatory care, and where not only do they do things for the baby, but they actually take care of the baby on their own chest all the time. And this was particularly true for even immediate Kangaroo Mother Care. Health workers were convinced that once the mother comes into the NICU, there would be more infections. And this study has shown that the infection rates are actually reduced when mothers are there to take care of the babies. So I would think that the main thing that we sort of need to do is to create an environment where Kangaroo Mother Care is a culture and the health workers are totally convinced about it. Over.
Thank you. Vicky, I think there are 2 questions in the Q&A.
There are. So Ola was up first, I think. I don't know, Ola, if you can unmute yourself if you would like to ask your question directly. Otherwise, I can do it for you, but you might prefer to speak for yourself.
Yes, I can't unmute myself, but you could. Do you hear me now? Yes, thanks. So thanks for great talks, and both Dr. Rao and Dr. Linnér. This is really interesting and very important. I have actually two questions, and the first one is, of course, about delayed cord clamping, because I remember myself not finding any mentions on how if it was recorded in your studies, as it's also a very inexpensive intervention that could help out or complement this very important Kangaroo Mother Care. So that's just with the first question. The next comment is that in the NICU where I work in Lund, especially, so it's usually the nurses that are mostly engaged in working with skin-to-skin care, and they are concentrating on the extremely preterm babies. So they forget. Let's talk about that. Or that's what the babies from 28 weeks or 30 weeks up to 35 weeks. And do you have any studies on the intervention of skin-to-skin or KMC in high-income countries, in these a little bit less preterm babies?
I can answer that because that's my my doctoral project, and I'm in the middle of looking at Swedish registry data. And you're right, Ola, they are forgotten. And I mean, in Sweden, for those of you who are working elsewhere, in Sweden we are registering daily skin-to-skin durations and initiation times into our national quality registry. And of course there may be underreporting, but according to the data, skin-to-skin duration per day is super low, like a couple of hours, and initiation is done late. And I have the same experience as you, Ola, that the nurses seem to get some kind of early, meaning after a couple of days or so, skin-to-skin contact to sort of get the families together, and then it's forgotten. And especially when they move to the family rooms, the babies stay in their beds, actually. So I don't think we're doing what we can really in Sweden in terms of skin-to-skin contact. Apart from that registry study and the studies we're doing at Karolinska about immediate skin-to-skin contact, then I don't know, maybe you know, Suman, of other studies about like very preterm infants or a bit bigger infants and skin-to-skin contact.
No, I'm not aware of something which has focused only between this 28 and 32 weeks, but the Community-Kmc study showed that it reduces mortality even in the bigger babies between 2 and 2.5 kg. And that's, but yes, I mean, I think as far as nurses are concerned, they are so much, you know, they have to do so much for the preemies, the very small extreme preterms, that once the baby is sort of better or babies are bigger, Kangaroo Mother Care requires a lot of support even in them to make sure that they do. I mean, you do get, like you said, 2 hours, 3 hours of KMC, but to make them do like in double digits, 10, 12, 15 hours, that is the big challenge.
Yeah. I really think it's terrible to find these parents. They are lying in Sweden, you know, both the parents could be in the family center care room, but they have their baby in the small bed. And so it's but what about in Vienna or in other countries? Are you better on taking care of the children in that, or the neonates in that a little bit older?
So from the UK, I can say I'm only from my unit that I work in experience. I can't say for the whole of the UK, but to get 16 hours of skin to skin or Kangaroo Mother Care, I just think would blow all of our minds. I think it would be very uncommon. It's definitely not a normal culture for us yet, I would say.
May I just sort of butt in a little bit here? And in fact, in the immediate KMC study, even for us, it was mind-boggling to see an average of 20 hours per day. And this was both in the intervention arm and the control arm. And thinking back of what could have made this big difference was that we had this KMC support team who were not nurses. They were actually just young girls, and except in Malawi, they were a little older. But their only job was to support Kangaroo Mother Care, help the baby, remove. They did not have any other medical responsibilities. And probably they made a big difference. So they got the mother and the surrogates to do prolonged KMC, which became a sort of, ingrained in them. And they continue to do so even when they got transferred out from the NICU to the KMC ward. And even in the KMC ward, these KMC support team would visit them and encourage them to do prolonged KMC. So maybe a non-medical team would help us achieve this much more than, I think, doctors and nurses.
Because I imagine that it's a little bit the same as with delayed cord clamping, that it will save lives, especially in low-income countries and in preterms, but it will affect the development and the parental bind, the connection between the child and the family, the parents, in less premature babies. It's very important in all births, of course.
Thank you. I really agree, Suman, that I think having separate specialized teams to implement any sort of change, I think is a huge value, mostly I guess because other people are busy and they have that and they take that on as a champion role. I think that is, in terms of implementation, I think that's really important. We have Nicholas Embleton as well, who's also got a question. He's also put no exclamation mark, and I think maybe that's about whether or not we're good at doing kangaroo care in the UK, but I'll let you unmute yourself, Nicholas, and ask your question.
Yeah, I think I've been unmuted. Can you hear me?
Yes, we can hear you. Thank you.
So thank you very much to the two speakers. That was they were great presentations. And yeah, you're right, Vicky. We are appalling at doing skin-to-skin care. I mean, the units, the doctors, the nurses, all collude together to think of every reason why the baby should not be having skin-to-skin. And we need to get an awful lot better. My question was really just about caffeine. I know that's not the focus of this study, but I work with a group across sub-Saharan Africa looking at sort of nutrition primarily, but it only became apparent to me that in all of these NICUs or SCBUs across Africa, none of them have any access to even oral caffeine. And that seems astounding, given that to get there, I had to drive through fields growing coffee itself. And you will all know that there's a pharmaceutical company that makes caffeine and is charging a ridiculous amount of money. Yet the raw material to provide it is incredibly cheap. So we have a sort of paper coming out and we're kind of actively looking at this. But I was just interested. I mean, I'm not thinking about IV caffeine. I'm just thinking about oral caffeine. I mean, oral caffeine may stop the babies having apneas. It might be another reason to just leave the baby with the mother. Whereas as soon as the baby has an apnea, the temptation is for people to whip the baby off and put it in an incubator. So do you have any data on which of your countries and in this kind of 1 kilo to 1.5 kilo range, which of those babies were actually getting caffeine at all? Do you know?
Shall I just sort of, I mean, in the study as such, in the Ikmcm study,
yeah,
they were not routinely using caffeine. They did use aminophylline when a baby's had apnea, but this was not true across all the sites. We did not capture data on this, but this is basically what we have seen in our monitoring visits, that we know they didn't use it routinely in the sites. But yes, caffeine is probably another thing that they will have to focus on because the evidence is so strong in that.
Yeah, I mean, there's a question about whether it should just be made available or whether people still need trials. I mean, of course, in the CAP study, we didn't actually see a reduction in mortality. We saw better neurodevelopment, but it's not been shown to reduce death. Whereas you might imagine that in lower middle income country settings, the context is very different and the outcomes might be quite different. And you might imagine that it would be associated with lower mortality because there's less need to put IVs in, low risk for sepsis and all these kind of things. So I think it does deserve a good study. But to me, it seems outrageous that these units are using aminophylline, which is a far less good drug. It's a far more dangerous drug. And really, you know, caffeine is probably the easiest drug or one of the simplest drugs to procure and supply. And yeah, I think, yeah, for another time really, but it's interesting that in your study, they're still using aminophylline. Thank you.
So, are there any other questions from the attendees that we have not brought up?
Not at the moment.
I have a very short question, or yeah, not so short maybe, but maybe a short answer. So, were you surprised about the findings in the secondary outcomes when you were thinking about the mechanism of action? How did it work?
I don't know if you want to answer to that, Suman, but as I said, well, yeah, the breastfeeding outcome was a bit surprising because we figured that that would be a very strong protective effect for a child in a setting with a low nurse to child ratio, that the mother stays with the child and breastfeeding is probably initiated earlier. That was our hypothesis. So yeah, that was surprising. I don't know about you, Suman. We did some post-hoc analyses as well. Now I'm not remembering them, but maybe you do.
Yeah, I just wanted to add that so we were surprised by the breastfeeding outcome, that it didn't really make a difference. But also the point to note is that both in the intervention and control arm, exclusive breastfeeding rates was about 85%, which is very huge. And that is understandable considering that even in the control arm, by the time they got discharged, they were doing something like 19-20 hours of KMC per day. So probably that's one thing, that both got good kangaroo mother care, and therefore when we looked at neonatal and end of the neonatal period and exclusive breastfeeding, we didn't find a difference. So we did a post hoc analysis and we looked at a few things which showed a remarkable difference. One was the time to put to breast. In the immediate KMC, they were all put to breast like in 1 day, 2 days. Even the smallest babies were put on the breast. Exclusive breastfeeding rates at the time of discharge was higher in the intervention group, but by the end of the neonatal mortality, it had sort of similarized. So there were more opportunities for breastfeeding in the immediate intervention, in the immediate KMC arm, and the post-hoc analysis did show that. For me, what was surprising was the time to stabilization, which we had defined very well, was not very different. And that was something that we struggled to try to explain. And I don't think we really have a good answer to why was the time to stabilization in both these groups very similar to each other. Over.
So thank you so much for replying so thoroughly to all these questions brought up. So do we have any final comments or questions or reflections from the attendees or from you, Dr. Linnér or Dr. Rao?
Hello.
Hello.
This is Björn Westrup.
Hi, Björn
Can you hear me?
Westrup. Yes, we can hear you.
I'm sorry, my camera doesn't work. Well, I just wanted to say something about Ola, the cord clamping. I was also very much involved in this Ikmcm study. And I can tell you from experience that immediate KMC is, of course, extremely helpful for late cord clamping, because I think Agnes and Suman can second me on that. In most institutions, they cut the cord extremely quickly, and they wanted just to get rid of the child as quickly as possible. So I think immediate KMC is very important for delayed cord clamping. Yeah. Also, I think it's so very important to remember that in this Ikmc study, we actually introduced the concept of mother-newborn couplet care, which is an extremely important systems change that is needed, not only to put the baby's skin to skin immediately, but you need to have an opportunity to provide medical care to the mothers and the infant in the same unit, in the mother NICU or whatever you call it.
Yeah.
So it's a big challenge, but the savings of lives, I agree with Suman, it's around 400,000 babies per year if you can provide as good KMC after the stabilization period as we did in the Ikmc study. That's why we had so good results for breastfeeding, as you pointed out. So enormous potential of saving lives.
Yeah.
Yeah, so scale up is the word to use and to do and what to do. So I think with that comment, thank you, Björn. I would like to close this session and say thank you again to Professor Swartling Peterson, Doctors Linnér and Rao. And I would also like to wish everyone welcome to our third webinar that will be held sometime in later January. So stay tuned on our website and see you next time. Many thanks. Bye-bye.
Thanks,
Thank you.
everyone.
Thank you.
Bye.
Bye.